Hello, let's talk about splenic disorders. We start with a fairly unusual case. A 35-year-old woman has a medical history remarkable for liver cirrhosis and portal hypertension secondary to chronic hepatitis C. She presents with splenomegaly and a pancytopenia. And so the concept delivered to you in this case is that the spleen is a filtering organ. And when you increase the blood pressure within the spleen, as you do in cirrhosis, because venous blood leaves the spleen to go to the liver, when you increase the pressure in the spleen, you will increase filtration, and thus you will increase the amount of cells that macrophages of the spleen pull out of circulation and pop, leading to the pancytopenia. Now, the spleen is also a hematopoietic organ. It is a site of extramedullary hematopoiesis. In the event that you have a bone marrow problem, you will see a splenomegaly because it will be making red blood cells. It has a capsule composed of fibrous tissue, and it's got a hilum or a root, kind of like how your lungs have a hilum and your kidneys have a hilum, meaning that the arteries go in and the veins go out at the same part of the organ. That's the hilum. Now, splenic parenchyma is divided into white and red tissue, or pulp as we refer to it as, and white pulp has almost a purely immunologic function. It's filled with beta or B lymphocytes, B cells, that are able to make immunoglobulin whenever antigen presenting cells show them various antigens. And so as blood passes through the arteries of the white pulp, APCs grab hold of a lot of different things that are in the blood, and they show them to T cells and B cells, and they'll trigger an immunologic response there. And B cells, again, specifically, are in the white pulp. Now, the red pulp, that's where filtration takes place. That's where red cells have to squeeze down to a very small size, about a 2 or 3 micron diameter, and fit through these splenic capillaries. And this is also where you have macrophages who perform the function of taking any red cells or white cells or platelets out of circulation that have been opsonized or marked for removal by something like C3b of the complement cascade or IgG, right? So this is a great diagram showing you really the splenic circulation with a directional component to it. You know, it's going to enter through these arteries and go from the white pulp to the red pulp in a sequential fashion. And then blood will pass through these penicillary arteries and then eventually through sheathed capillaries, which is where filtration occurs. And then they're going to exit the capillary bed and go into venous circulation, labeled by the pulp vein here. So there's a little bit of an open circulatory space. This spot right here is kind of referring to the transitional zone where capillary blood becomes venous blood. There's open circulation, and then there's venous blood. The spleen, due to the white pulp having so many B cells, is the major site of IgM production in the body. Remember, IgM is a pentamer. It's the rapid response immunoglobulin, and you don't have the class switch out of anything. IgM is the default for B cells. So IgM opsonizes bacteria, tags them for destruction, and then macrophages of the spleen are very important in pulling those bacteria out of the bloodstream, just like how those macrophages pull senescent red blood cells out of the bloodstream. So this is where the SDL kind of talks about, you got to talk about this somewhere, and here's where it talks about it. Encapsulated bacteria, what a capsule does for a bacteria is it makes it slippery, you know, like slippery. Like, so you pick the bacteria up and it just falls out of your hands. It's that slippery. So in order to hold on to bacteria, you've got to opsonize it first with IgM and IgG. And when you opsonize an encapsulated bacteria, that lets macrophages hold on to them and eat them up. So if you opsonize encapsulated bacteria, you can eat them and get rid of them. But if you do not opsonize them, they are so slippery because of their capsule that you cannot phagocytose them and get them out of the bloodstream. So therefore, because the spleen is the major site of IgM production in the body, and because it filters your blood, it throws IgM on bloodborne pathogens. If you are asplenic, you don't have a spleen. What that means is you are at a greater risk for infection, specifically sepsis, any bloodborne infection with an encapsulated bacteria such as Streptococcus pneumonia, that's got a capsule, or Neisseria meningitidis, that also has a capsule. So vaccination status for patients who are asplenic, very, very important. Here's a table talking about functions of the spleen. I usually don't like tables, but I like this one, and I'm gonna go over this before the exam because this does look like something, some sort of thing you could write a test question from very easily. You know, like here's the function. You know, like hematopoiesis. What part or anatomical part of the splenic tissue is responsible for that? And so, in this case, cords and sinuses. You have stem cells there. So we mentioned briefly the spleen also takes red cells out of circulation when they are senescent. And they also kind of pat down red blood cells. And if there are any inclusion bodies in a red cell, the spleen will take care of that because you don't need red cells flying around the bloodstream with a bunch of crystals within them. So a few different things can crystallize inside a red cell. And predominantly, it's going to be hemoglobin, and that would be called a Heinz body. Or sometimes when a red cell matures, you know, it spits out its nucleus at some point along the way. And sometimes not all of the nucleus gets expulsed from the red cell. A little bit can stay behind. And when you see part of a nucleus left behind in a red blood cell that shouldn't be there, that's called a Howell-Jolly body. And so the spleen also pats down these red blood cells. If it finds a Howell-Jolly body, it says, all right, mine, you know, and then it takes it out and hopefully just doesn't kill the red blood cell and it sends it on its way. So the concept here is that if you don't have a spleen, you will see these inclusion bodies in red blood cells on the peripheral smear. And when you see them, it will tell you that the patient's spleen is non-functional. So let's visualize these things now. Let's take a look at it. Here's white pulp of the spleen. And again, you've got follicles, germinal centers, and there are B cells right in the center of this follicle, and they're going to get activated in response to any antigen and start making some IgG. Here's the red pulp on the right side. Notice how many erythrocytes are in there. These sinuses taper down and get very, very narrow, and so this kind of tests red blood cells to see if they can deform enough to fit, and if they don't, they just lyse, and that's going to be an extravascular hemolysis. Here's a little bit more zoomed out picture here. On the left side, we've got white pulp with a periarteriolar lymphatic sheath, and on the right side, we've got red pulp. As you can see, there's less lymphocytes there, more just plain red space, indicating connective tissue. So here's a Howell-Jolly body. A Howell-Jolly body is part of a red blood cell nucleus that just stays behind whenever a reticulocyte, remember a premature red blood cell, you go to, what is it, polychromoblast to orthochromoblast to reticulocyte to erythrocyte. And so at the orthochromoblast stage, you're supposed to spit out the nucleus if you're a red cell. And so again, sometimes you spit out 90% of it, but 10% stays behind. That's what the Howell-Jolly body is. And so when one of these cells with an inclusion rolls around to the spleen just grabs it and takes it out. So if you see these red cells in a peripheral smear, and they've got very many of them have these Howell-Jolly inclusions, they're just little dots, you can infer that the spleen is not functioning. And so the Heinz body is something very similar. Concept is identical, but what is in the inclusion is different. Instead of this being a piece of DNA or nuclear remnant, as in the Howell-Jolly body, the Heinz body is a big clump of crystallized hemoglobin. So a thalassemia in which you've got disproportionate amounts of each globin chain being made, in an alpha thalassemia, you've got trouble making alpha globin. And so you've got to make some beta tetramers, right? Some beta globin tetramers. That's called hemoglobin H. And then if you had a total knockout of the alpha globin chain, you would be making gamma globin tetramers, and that's called hemoglobin Barts. And so those are non-functional hemoglobins, and they polymerize and crystallize together. And that's what the Heinz body is. So the spleen is also responsible for taking these things out. And if you see a bunch of crystallized Heinz body inclusions in red cells in a peripheral smear, you can infer that the patient's spleen is not working for whatever reason. And Heinz bodies are also seen in glucose 6 G6PD. What does that stand for? Something dehydrogenase deficiency, right? It's in the you make NADPH with it, and it's in your pentose phosphate pathway. That's it, right? That's the one. So if you're deficient in that enzyme, then you're also going to have a lot of radicals floating around the cell, and those radicals are going to damage hemoglobin. And when hemoglobin gets damaged, then it starts to also aggregate in that situation as well. These are bite cells. And so up to this point, the concept is if the red cell has something stuck in it, be it that or that, the spleen grabs it and takes it out. Well, to do that, the spleen literally takes a bite out of the red blood cell. So, it's not like it's not a chomp. It's kind of like a nibble. It's just like a little slow, little tiny bite. And so you can tell that this red blood cell has just had a little baby bite taken out of it, and this one too, just a small little bite, just a taste test. The spleen doesn't want to eat the whole red blood cell. It's a good, fine, normal red blood cell. It just wants to take out the inclusion body. And so that's what it does. These are bite cells. If you see these in the peripheral smear, you can infer that, there must have been a lot of inclusion bodies in these red cells for the spleen to have taken so many bites out of so many cells. So those are bite cells. You see them in thalassemias, in G6PD deficiency, same conditions you would see Heinz bodies in. So the way that question could get asked is either they could give you these cells on a peripheral smear and ask you what condition the patient has, whether it's asplenia or G6PD deficiency, or they could flip it and give you a patient with alpha thal or G6PD deficiency, and they could ask, what would you expect to see amongst red blood cells in peripheral smear? And so then they'd give you 4 or 5 different morphologies, and one of them would be like crystallized basophilic inclusions, and it's like, that's the one you're looking for. So now, bottom of page 4, top of page 5, telling you that the spleen typically just yanks these inclusions out of red cells. If you don't have a spleen, you can't get rid of the inclusions. Here is a paragraph that I'll read out loud just to say that we did. Tuftsin is a tetrapeptide produced in the spleen by cleavage of the FC domain of the heavy chain of IgG. So FC, that's fragment crystallizable, or also known as the constant region. Every immunoglobulin has a constant or conserved part that is identical across all IgGs, and then they have a variable region, and that's the part of the Ig that gets recombined to bind a particular antigen. So Tuftsin has an immunostimulatory effect. It's chemotactic. It's an opsonin, and it stimulates bactericidal activity in immune cells and enhances antigen uptake. So serum Tuftsin concentration is significantly reduced in splenectomized patients and individuals with hyposplenism. I'm reading this out loud just in case patient that doesn't have a spleen, one of the answer choices is, oh, low serum Tuftsin. You never know. Something similar, hyposplenic and splenectomized patients show markedly reduced uptake of technetium 99, and that is scintigraphy, or also known as a radionuclide scan, right? You could have like technetium, gadolinium, you know, you could have a who's-a-whatsinium, a lot of different iniums out there. And we use these things to find different things in the body. For example, with a Meckel's diverticulum, remember that we can look for ectopic gastric tissue by applying this radionuclide scan that's specific for tissue of the stomach. Now let's talk about asplenia. It can be congenital or acquired. With congenital asplenia, there's a couple different types. It can be isolated congenital asplenia, in which that's really the only problem the kid has is they don't have a spleen. So if you don't have a spleen, again, you are more susceptible to infection by encapsulated bacteria such as strep pneumo and Haemophilus. And then there's this congenital asplenia and polysplenia syndrome. And this is actually two different syndromes. Either you have congenital asplenia syndrome or you have congenital polysplenia syndrome. So they are what they sound like. Asplenia, you don't have a spleen. Polysplenia, you actually have multiple spleens. So I found a good little graphic to take a look at this. Here is congenital asplenia, and in this disease, the patient actually has a very wide liver that spans the entire left to right width of the body. And so if the liver is going to go, if the liver is bilateral, essentially, there's no room for the spleen to grow. So this is the congenital asplenia syndrome. And again, it's associated with all sorts of cyanotic cardiac heart defects. And you're going to recognize those because baby's going to have a low APGAR. They're going to be blue cyanotic around their mouth or peripheries, right? So here is congenital polysplenia. And in this situation, you've got a situs inversus of the thorax, and the abdomen is normal, and that the abdomen isn't mirror image. It's not flipped. It's not reversed. But you do have a few spleens, and they're all right next to one another on the same side of the body. So it's not like you got a spleen in a normal spot, then like a spleen down in your knee and a spleen in your shoulder. You know, it's like, no. They're all right there where one spleen should be. You just have 2 or 3 or 4 of them. So that's congenital polysplenia. And again, you've got a cyanotic heart defect with situs inversus of the thoracic viscera. So they tell you to question, patient's got 5 spleens. What else do they have? You're going to say, oh, they've got the situs inversus. And then there's acquired hyposplenism, much more common than congenital. Sickle cell disease, you always see splenic atrophy due to repeated infarctions. And in sickle cell disease, you've got these sickle cells clump and they occlude blood vessels, and so then everything distal to the blockage just sees a drop in oxygen supply, and that happens very easily in the spleen because of the tiny compressed nature of the capillary beds there. It's a filtrating organ. It's supposed to have small capillaries, and so the odds of getting a sickle cell crisis in the spleen are very, very high compared to any other organ in the body. So that's why you always see an infarcted dead spleen in sickle cell disease. It initially swells up, and this happens at about the age of 2 or so. But by the time the patient is 18 or 20, their spleen is going to be the size of your thumb. It's going to be so tiny, practically gone. It's just going to be basically an artery and a vein, and that's your entire spleen. So again, you have an increased risk of infection with encapsulated organisms, especially strep pneumo and Haemophilus. That's popped up like 5 times in this SDL. I imagine you'll see a question about that somewhere along your road. And what you want to know is that you're going to get these kids the pneumococcal vaccine. And Haemophilus has a vaccine too. And I can't quite remember what type it is off the top of my head. It's a conjugated polysaccharide capsular vaccine. That's it. against, what is it, polyribosyl phosphoribosyl, PRP, something like that. That's the Haemophilus vaccine. So they could ask you different vaccine. They could give you a sickle cell patient and end up asking you an immunology vaccine question. You're sometimes hyposplenic following a bone marrow transplantation, and we don't really understand why. So maybe it's because, number one, your spleen has a whole lot of B cells, a whole ton of B cells. Number two, B cells aren't made in your spleen, they're made in your bone marrow. So number three, if you've got to immunosuppress somebody to give them a bone marrow transplant, then their spleen is just going to shrink and atrophy because it'll have less B cells in it eventually. So that kind of makes sense to me, right? Now, celiac disease is, quote, the most frequent disorder associated with hyposplenism. So keep your eyes open for celiac association on test question. Remember, hallmarks of celiac disease, it's a enteropathy, you get malabsorption, so presents as a steatorrhea. You're going to get specifically fat malabsorption because typically it's going to be the ileum and the jejunum that are affected. And, bile salts are reabsorbed in the terminal ileum. And so you can also commonly see a bile salt problem here. And that's going to lead to the fat malabsorption alongside the torn up gut mucosa. Now, it's an autoimmunity against gluten. And specifically, you're making IgA, immunoglobulin A. That's pretty particular to celiac. You're making IgA against this thing TTG. It's an enzyme called tissue transglutaminase. And you might also see the word gliadin thrown in there. And gliadin is just a subcomponent of gluten, okay? And so it's associated with HLA types DQ2 and DQ8. And one last thing is that you very commonly see this rash. It's a vesicular skin rash that patients with celiac disease get, and it's called dermatitis herpetiformis. And it's called that because it looks like herpes. It's got the same form as herpes, but it's not herpes. So normally, where do you get herpes? Mouth and the genitals. And so if you see something that looks like herpes on the elbows or, the knees or the stomach and back, then you're suspecting it could be this dermatitis herpetiformis that is unique. It's virtually pathognomonic for celiac disease. So asplenia, functional asplenia patients with celiac. Corticosteroid therapy impairs the affinity of the FC receptors of splenic macrophages for opsonized IgG. So we mentioned the FC part of IgG. Remember, every immunoglobulin G looks like a Y, and the FC part is going to be kind of like the base of the Y, and then the variable or recombined part of the antibody are going to be the two tips of the fork of the Y. And so this FC part of the Y literally binds to a receptor on the surface of immune cells. And so if you were on prednisone, for example, a glucocorticoid, then this FC is going to bind to its receptor with a diminished affinity. It impairs the immune response. That's why corticosteroids have a slight immunosuppressant function. So this is going to result in functional splenectomy, functional asplenia. You still have a spleen, it's still functional, but the ability of the spleen to process antigen and antibody is completely impaired because you're on this corticosteroid. We talk about Howell-Jolly bodies again. Those are DNA fragments that get trapped in the cell, red blood cell, and typically the spleen just goes in and grabs them and takes them out and leaves the red blood cell alive and sends it on its way. So if you see Howell-Jolly bodies in peripheral smear, the patient has functional or practical asplenia or hyposplenia. Now, if you don't have a spleen, you are definitely at risk for a lot of infections. There's this one particularly called overwhelming post-splenectomy infection, which the name tells you exactly what it is. It is an overwhelming post-splenectomy infection. Starts off kind of flu-like, can transition very rapidly to a bacteremic septic shock. Remember, the spleen filters your blood and it yanks bacteria out of your blood. So if you don't have a spleen, you've got bacteria in your blood, which is literally sepsis. So that's going to be accompanied by a fever, hyperpyrexia. Why? Interleukin 1, TNF alpha in the blood. Bacteria make those things, right? So headache, inflammation, inflammatory cytokines there, hypotension due to the lipopolysaccharide that can cause septic shock, right? It's going to drop your blood pressure by vasodilating you peripherally. And DIC is going to follow that septic shock a day or two later. And what's that going to look like? Well, patient's going to have several thromboses in their small vasculature. And so because they're clotting, they're going to use up all their platelets and all their factor. And so if you took a blood draw, their PT, PTT bleeding time would all be prolonged. And they would be bleeding very easily out of their gums, out of the insides of their mouth, maybe in the GI tract, because they were totally depleted of platelets and factor. And so that's your DIC presentation. Also remember in DIC that D-dimers are elevated, or fibrin split products. So that's your post-splenectomy infection. So vaccination is recommended. And when do you want to give these patients the vaccine? Prior to splenectomy. Oral penicillin is furthermore recommended as prophylaxis for asplenic patients, especially if you catch sickle cell very early on. Again, you'll be functionally asplenic by 2 or so years of age. And so oral penicillin, when kids are really young, remember, think about yourself, like unless you're immunocompromised, you probably got a lot of infections as a kid, but then you hit the point where you had a mature immune system and you kind of stopped getting sick. And so kids are more prone to infections is the point I'm making. And so you want to prophylax while they're a kid, but then eventually you can take them off it. Patient doesn't have a spleen, you definitely want to give them some antibiotic before they get a tooth pulled, because that is a very tough wound to heal. Teeth are highly vascular, very, very, very vascularized. And not only that, the oral cavity is just swarming with all sorts of aerobes and anaerobes. Let's talk about splenomegaly. Splenomegaly is never a disease in itself, but usually indicates some underlying pathologic state. So the case that we talked about at the introduction of this SDL had splenomegaly in response to portal hypertension. So blood got backed up into the spleen. That's a very easy mechanical cause of splenomegaly. Common causes of splenomegaly include leukemia, lymphoma, and hemolytic anemias. Good table here, pathophys of splenomegaly. In a hemolytic anemia, let's just take, for example, a warm autoimmune hemolytic anemia. You've got IgG all over the surface of red blood cells for whatever autoimmune reason. And so they opsonize the red cell. The red cell gets to the spleen and macrophages take it, grab it, pull it out of circulation. So the more often that happens, you got to put those red cells somewhere, you pull them out, you got to pop them and eat them. And so the spleen's going to get real big as you're doing that and sequestering more and more and more red cells inside it. Same thing with a autoimmune thrombocytopenia, for example. Now, if you had a bad infection, spleen could swell up there. And particularly in mononucleosis, splenomegaly is just about characteristic feature of that disease. Compensatory extramedullary hematopoiesis. The spleen is a filtering organ and it's a hematopoietic organ. So when you have a leukemia, which is a bone marrow cancer, those present with cytopenias because this cancer in the bone marrow is growing and expanding and crowding out red blood cells and platelet precursors, megakaryocytes and white cells from proliferating and getting into the blood. So because leukemia is present with or typically anemias and thrombocytopenias, definitely, then you're going to need to correct the anemia. And your body tries to do that by getting the spleen to make blood cells. When it does that, it swells, splenomegaly. So same thing with lymphoma there. Portal hypertension, again, simple mechanical cause, makes sense. And then Gaucher, remember tissue paper macrophages. Niemann-Pick disease, remember sphingomyelin, very similar to Tay-Sachs. I think you can get a cherry red macula in that. And hepatosplenomegaly is actually how you tell Niemann-Pick apart from Tay-Sachs. Gaucher's is, I think, going to be glucose cerebrosidase. And yeah, Niemann-Pick again, sphingomyelin. Hypersplenism refers to non-immune, indiscriminate destruction of the formed elements of the blood by an enlarged spleen. The bone marrow is hyperplastic and the peripheral blood cell counts are decreased because of destruction of mature formed elements. Splenectomy corrects the cytopenia. So you can have an anemia, you can have a thrombocytopenia, you can have a neutropenia, total leukopenia, because the spleen would be taking those cells inappropriately out of circulation. So actually, what we saw in the very first example with, again, portal hypertension due to liver cirrhosis, the spleen is a filtering organ. Filtration is a function of blood flow. When there's liver cirrhosis, portal hypertension, blood backs up into the spleen. So by default, filtration increases. That's a hypersplenic state. You're taking more cells out of the blood as a function of filtration. And autoimmune diseases can also lead to hypersplenism because autoimmunities are associated with systemic inflammations, high levels of pro-inflammatory cytokines that are going to activate splenic macrophages and get them very riled up against the cellular component of your blood. So takeaway from this paragraph for two, hypersplenism means there's a cytopenia because the spleen is swollen and it's super filtering, it's ultra filtering your blood inappropriately, and it's taking too many cells out of your blood. Other splenic disorders. You can get an abscess, and that's typically after an endocarditis. Remember, with an endocarditis, you have vegetations growing on a heart valve. And so if it's very acute and fulminant and typically right-sided with an IV drug user, we're thinking Staphylococcus aureus. If it is subacute, meaning symptoms, fatigue, sweats, progress gradually over 2, 3, 4, 5 months, then we're thinking most commonly a species such as Strep viridans, which is an alpha hemolytic gram-positive coccus that's got dextrans. Remember, that's a virulence factor that helps it adhere to heart valves. And then there's also, don't forget about culture-negative endocarditis, such as Coxiella, right? Q fever, and also, what was it? Starts with a B. I'm forgetting it right now. But yeah, you could have a culture negative endocarditis too. A lot of different causes of endocarditis. So vegetation breaks off, goes to the spleen, infarcts it a little bit, could cause an abscess if the particle that breaks off is coated with bacteria. And again, remember endocarditis, the same concept you can see in the fingers. You would have those Osler nodes and Janeway lesions, right? On the nails or on the fingertips. And those would just be little micro abscesses or chunks breaking off of that endocarditis and going to the fingertips and getting stuck there. And so you can see that in the eyes too. And I think those are called Roth spots. You'd be looking at the eyes and see these little pools of blood, and it would be due to this endocarditis that has a little piece break off and go up to the eye and just occlude a small vessel in the eye. So endocarditis, you've got clots of bacteria just floating around in the bloodstream that could cause a splenic abscess. Splenic infarction, when you see this, probably most commonly would be atherosclerotic embolic disease or AFib, but sickle cell disease is also going to be a very, very common cause of splenic infarction. Again, in sickle cell, the spleen always auto-infarcts. It is inevitable, and it typically occurs by age 2 or 3. And again, we're talking about sickle cell disease there, not sickle cell trait where you're a heterozygote. We're talking about the homozygous sickle cell disease. So you just treat the underlying condition there. And splenic rupture, lastly, football player or maybe a diver, I don't know, from like a 20 or 30 foot height, somebody in a contact sport gets hit on the left side of their body and the spleen just pops. It's an encapsulated organ, which means that it's kind of mush inside the capsule. Otherwise, it wouldn't even need a capsule. And so if that capsule ruptures, you can get very, very large hematomas. That's a bad deal. Got to go do an exploratory surgery to find those blood clots and vacuum them out. And anything that gives you splenomegaly will predispose you to splenic rupture. How could it not? In splenomegaly, the spleen is just a bigger target and it's got more tension stretched out across its more tense capsule when it's enlarged. So that is the spleen. Now let's discuss Langerhans cell histiocytosis. I'm going to summarize this, and then I'm going to tell you what you need to know for boards, and then I'm going to pick it apart piece by piece for our in-house exams. So LCH is technically a cancer. It's a clonal proliferation of histiocytes, which is kind of a Shakespearean way of saying macrophages. And typically kids get this cancer. Over 80, over 90% of Langerhans cell histiocytosis happens in kids. Now, there's about a 2-to-1 guy to girl ratio, so it's typically a little boy. And this kid is going to present in a question stim with lytic bone lesions, kind of like multiple myeloma, and or eczema of the skin, so a big widespread rash. And those are going to be your two tip-offs that it's LCH. Now you have to do a biopsy to confirm this diagnosis. And when you do a biopsy, you will stain for CD1. And if it's CD1 positive, that should get you a little bit worried. You can also do electron microscopy in which you'll find Burbeck granules. We'll look at those. And finally, all Langerhans cell histiocytoses characteristically have a BRAF mutation. So those three things right there that I just mentioned, that's really what USMLE Comlex questions will test you on, because this is a very rare disease, very rare. And they do not expect you to be experts on it, but they do expect you to recognize it and at least understand the gist of it. So the Langerhans cell is an antigen presenting cell. So it's essentially a macrophage, hence the histiocytosis. But the Langerhans cell is particular to the skin. And normally, Langerhans cells in the epidermis just are patrolling, you know, they're riding around like the cops, looking for somebody to pull over. And they're in the skin when they're doing this. And so when they find someone, they're like, oh, we got a speeder. He's going 3 over. And so they just drive by and accost the guy, you know. And so they slap some cuffs on him because speeding is a huge crime. And they take him to the nearest lymph node where the B cells in that lymph node are going to pat this antigen down. And if it's appropriate, they will start making antibodies against that antigen. So that's what Langerhans cells do. They find some antigen, they take it to a lymph node, they show it to B cells. In LCH, these Langerhans cells, there's a clonal proliferation of them. So it's essentially a cancer of the Langerhans cell. And they're non-functional. They can't do their job in LCH. So instead of grabbing an AG and taking them to a lymph node, they just kind of sit around like, you know, the old stereotype, the cop just sitting in his car eating a donut, you know, with his coffee and his 12-pack of donuts. Like that's the Langerhans cell in LCH. It's not doing anything. It's just sitting there. So these cells just form clumps and aggregations throughout the body, most commonly in the skin, but there is also a predilection for bone, hence the lytic bone lesions this condition typically presents as. So again, you want to know that LCH is a disease of children for all purposes of the test question. You can see it in adults. It's much, much more rare. There are subtypes of this disease. I won't get there quite yet because first we talk about pathogenesis. Virtually all LCH patients have BRAF V600E valine 2-glutamic acid at the 600 position mutations. So that's high yield. So BRAF plays a role in regulating the MAP kinase signaling pathway. If they don't ask you what is BRAF, like what is the mutation, then they could ask you what does the mutation do? So you got to know MAP kinase, cell growth factor pathway. LCH is a monoclonal proliferation of Langerhans cells. Okay, we said that. There is a coffee bean nucleus. It means it's got a groove in it. You know what a coffee bean looks like. And monoclonal Langerhans cells express CD1A. So when you biopsy it, you drop a little CD1 on it, and if it's LCH, it'll stain positive. You have to biopsy it to get the diagnosis. There's no way to just tell automatically. CD207 is a good stand-in for CD1A. You can also confirm the diagnosis by positivity for CD207. Now, CD207 is Langerhan, which is a protein that is pretty specific to histiocytes, and it's found inside these things called Burbeck granules. So in this photo right here, left side of the page, you are looking at Burbeck granules. These things look like badminton rackets, tennis rackets, or keys without teeth. So that's a Burbeck granule. This is a Burbeck granule. And you see them on electron microscopy. And understand that electron microscopy is kind of the diagnostic tool that we go to when nothing else really works. We've done every other workup in the book and we still have no clue what specifically this patient has. So we're like, screw it. Get out the electron microscope, okay? So it's a rare disease. That's why we use electron microscopy on it, and that's why it works, because there is a characteristic finding. And it's these Burbeck granules, very high yield. Again, they want to give you the presentation, the classic presentation of a young dude with eczema and a lytic bone lesion, and they want to say, what would you see on electron microscopy? Or maybe they'll show that to you and ask you to make the diagnosis. Okay, so now LCH has subtypes. I don't think that these subtypes are anything that ComLex or USMLE would particularly want to ask you, a second or third year medical student, about. I think that they want to give you the presentation of LCH and get you to make the diagnosis, or ask you, how would you make the diagnosis, okay? Because again, you want to know how to, but these subtypes this is not a disease that we understand very well. We know a lot about it, but we don't know it perfectly. And so it's not as high yield, as testable as other diseases in which we have the pathophys down to a T. So what these different presentations have in common, let's talk about that first and foremost. All LCH has generalized inflammatory symptoms, because it's cancer. So the kid's going to be running a fever, might be like up and then down and then up and then down. And the kid could be losing weight. And again, most typically, it's going to be a little white kid, boy. So this dude's going to come in and he's going to have this pustular eczema. And this is what it's going to look like. Often presents on the head, the calvarium, the skull is very commonly affected by this disease, this clonal proliferation of histiocytes. So that's what the eczema on the head looks like. And here is a more severe form called the multisystem LCH. And notice how this is a rash, but it's pustular. It's kind of forming scabs almost. So it's a bad rash. And if the kid walks in with bone pain, maybe it hurts to walk, it's deep, it's a throbbing pain, and it's constant, and NSAIDs don't make it go away, well, that's when you're going to get an x-ray, and you might find just a little punched out osteolytic lesion. That's also characteristic of Langerhans cell histiocytosis. There's a predilection for the skull and long bones. So nearly every LCH patient looks like that. Now let's talk about the subtypes. It's made a little bit more confusing because we had one way of talking about them, but now we have a different way. What I mean by that is we used to call these things eosinophilic granuloma, Heinz-Christian disease, Lederer-Sauer disease. But now we call it single system unifocal, single system multifocal, multisystem. So there's a little bit of a transition to a new terminology, kind of like GPA, granulomatosis with polyangiitis. Remember that used to be called Wegener's, but now it's called GPA. Okay, so we've seen this before. Let's start out with single system unifocal disease, otherwise known as eosinophilic granuloma. How I think about this is that the examples that I've seen of eosinophilic granuloma really have only had the bone involved, and maybe there's a little bit of a skin rash, but this is just a bone disease. And I want you to notice in this SDL that it says single system unifocal occurs predominantly in children aged 5 to 15 years. So if we go down and we look at the other subtypes of LCH, they actually present, according to the SDL, at totally different times of life. So what I'm saying is you could probably figure out the subtype based on the patient's age alone. The very severe type is in kids less than 2 years old. The intermediate subtype, called Heinz-Christian, is in kids 2 to 5 years old, according to the SDL, most commonly. And so then the most benign subtype is going to be in kids over 5 years old. So the age is important in telling them apart. Eosinophilic granuloma, osteolytic lesions, common presentation. They do bring up hearing loss because, again, the skull's commonly involved. And so let's think about conductive hearing loss. If you were to take a tuning fork and do a Rennie test in which you just kind of ding the thing and then hold it up to the patient's ear and then do it again and put it on the patient's mastoid process, then bone conduction would be greater than air conduction in the affected ear. And if you were to do a Weber test, which is when you ding the thing and put it on the top of the kid's head, then if you had a unilateral conductive deafness, then the Weber test, the sound would be louder in the affected ear because that's the ear that can't hear normally. So if you do hear something, it's like, oh, wow, that's really loud. So just remember, Weber's the one on the top of the head. Rennie's the one where you do air and then bone. Getting into the weeds of this SDL, eosinophilic granuloma patients demonstrate increased uptake in fluorine 18 labeled fluorodeoxyglucose. Oh, just reading that makes me say there's no way they could ask us that, but you know, stranger things have happened. When we say eosinophilic granuloma, there's literally eosinophils in the biopsy. So that's also particular to this subtype of LCH. Now, here's the eosinophils in the lower left part. And remember, this is a cancer. This is a neoplasm of histiocytes. So here in the middle of this slide are the neoplastic histiocytes with large nuclei and even larger pale cytoplasm. So middle is the neoplasm or the cancer, and over here you got some eosinophils. Eosinophilic granuloma of the spine develops in the vertebral body with an osteolytic appearance, and leads to a collapse and flattening of the vertebral body, classically known as vertebra plana. So you've got a planar vertebra. What does that look like? Looks like this. Look at that thing right there. This is an MRI, a couple different weights. That is a flat vertebra. So planar vertebrae is characteristic of eosinophilic granuloma. Single system, unifocal. This is probably the most important little bit in this entire section of the SDL, because this is the highest yield stuff. This is what they want to ask you about. The diagnostic criteria of LCH requires the identification of CD1 on immunohistochemistry or Burbeck granules on electron microscopy. I am pretty confident that's the extent of the questions you'll get asked on this, but just in case, let's keep going over single system multifocal disease, which is formerly known as Heinz-Christian disease. Again, this is going to be kids aged 2 to 5, and you've got bone problems, okay? And you've got skin lesions too. You're going to have that eczematous rash, but particular to this too, you've classically got exophthalmos or proptosis, which is when the eyes are bugging out of the skull, because the bone of the skull swells enough to get soft tissues involved. So the difference between this and eosinophilic granuloma is the soft tissue involvement. And also in classic Heinz-Christian disease, you can see diabetes insipidus. Why? The skull is involved in an inflammatory process. The pituitary sits in the sphenoid bone. So if the sphenoid bone is inflamed, don't you think it's possible the posterior pituitary might get a little agitated or impinged by that inflammation? I think so. So what pops out of the posterior pituitary? And the answer to that's arginine vasopressin, ADH, antidiuretic hormone. So couldn't you see there being a diabetes insipidus, a neurogenic DI if the patient just wasn't making any ADH? I could. Those are high yield for Heinz-Christian. Let's talk about Langerhans disease. It's multi-system, LCH. So it's multi-system because not only do you have the bones and the skin rash as you would in any LCH, you also have high-risk organ involvement, examples of which include the bone marrow, liver, and spleen. And because this has the most fulminant course and the worst prognosis, typically presents earlier on in life in kids under the age of 2 years. Wow, I am dumb. I said greater than 2. No, less than 2. There we go, less than 2. So less than 2 years old. Again, patients have fever because it's cancer, so there's cytokines in the blood, and bad organs are involved. Okay, I'm not going to read the rest of that. Let's look at a couple more pictures and call it a day. So this is Heinz-Christian disease, also known as single system multifocal LCH. This is just something else, you know. Like, that's really bad. And so the skin is involved. If you were to take an x-ray, the bone of the skull would be involved as well. And this is the intermediate phenotype. This is the severe phenotype, again, presenting in kids less than 2 years old, called Langerhans disease or multi-system LCH. And characteristic eczematous rash in a very young child. Again, you do an x-ray and you're going to find osteolytic lesions representing the migration of Langerhans cells into bone. You're also going to find little clumps of Langerhans cells in different organ systems, liver, bone marrow, places they should not be in. And one last time, you really want to recognize these Burbeck granules on electron microscopy. That is almost as easy as remembering my middle name. Nothing else that I've ever seen in 2 years of medical studies look anything like this. So Burbeck granules. And that's all that I have for splenic disorders and histiocytosis. Thanks very much. Have fun.